Hello, and welcome to our 23rd annual Gene S. Marx Memorial Education Forum. My name is Josh Marx, and I'm the CEO of Medical Service Company. Like in years past, today's event offers sessions from highly regarded healthcare professionals spanning the nation. We are honored to provide this premier education event in the sleep, respiratory, nutrition, and diabetes care disciplines for some of the most important healthcare heroes in our communities, you. We have an action-packed day for you with 13 distinguished speakers from universities, health systems, and supporting organizations. Before we get going, let me give you a quick lay of the land for today's program. This morning, we'll have 3 one-hour-long education sessions leading up to our keynote presentation. New to this year's program is our nutrition and diabetes track that runs concurrently with our morning combined sleep and respiratory sessions. Then, after a 30-minute break, the sleep and respiratory disciplines will split into 2 tracks. Throughout each session, you can submit your questions under the Engage tab just above the presentation screen. Speakers will address questions following their presentations as time allows. Sessions have been approved by the appropriate accrediting body for continuing education credits. Now, towards the end of each session, you will see a pop-up on your screen inviting you to evaluate the session and speaker. If you miss the pop-up or wish to fill out the evaluation later, simply click the blue button called Check-in Survey, located on the screen above the name of the presentation. At the end of the day, you'll be able to download your certificate from within the conference site. For any technical support, you can email us at jsmceu@medicalserviceco.com. Before we kick things off, I'd like to thank all our speakers, sponsors, and DME partners. Sponsors, thank you for your support of this event. We would have a very difficult time offering this type of event without your support. We all have a choice of who we do business with. Please consider these manufacturers and suppliers. They clearly believe in the DME channel and investing in home care. DME partners, it's inspiring to see us band together for the benefit of our patients and our partners. Today, we are all one team. Because of the valuable information being shared by our world-renowned speakers, we will be better equipped to care for the millions of Americans with home care needs. One more thing. Before each session, you're going to hear a little bit more about MSC from a few of our team members. To learn more about anything you hear and how we can support you and your patients, visit medicalserviceco.com. Now, let the forum begin.
Good morning, and welcome to our first Nutrition and Diabetes lecture series. We hope you are excited for this new track and enjoy the speakers we have for you today. I have the honor of introducing our first speaker of the day, Caitlin Omoregie. Caitlin earned her bachelor's degree in biology from Purdue University, then continued on to receive a master's in biology from the University of Akron. She later attended University of Texas Medical Branch, where she received her master's in physician assistant studies. Caitlin is currently working for University Hospital's Cleveland Medical Center in Cleveland, Ohio, as a physician assistant for the Division of Endocrinology and Metabolism. Caitlin also serves as a medical consultant for Dexcom and Boehringer Ingelheim to continue to develop continuous glucose monitoring technology and diabetes medications. Medical Service Company would like to thank Caitlin for participating in our forum, and we are excited to hear her lecture, How to Improve Diabetes Treatment Outcomes with Continuous Glucose Monitors. During this presentation, please submit any questions you have for Caitlin by using the Engage tab. These questions will be answered during the live Q&A portion of the lecture. To receive credit for attending, please complete and submit the evaluation at the conclusion of this session. Thank you.
Hi, everybody. My name is Caitlin Omoregie. I'm a physician assistant at University Hospital's Cleveland Medical Center. I work primarily doing inpatient diabetes management, but I've had the privilege of practicing diabetes management since 2017. So in my practice history, I've always had access to continuous glucose monitors, as I've only ever done diabetes management. So in today's presentation, I'm going to talk a little bit in detail about continuous glucose monitors. How do they work? B, how do I identify who could benefit from them and who could utilize them to their maximum potential? And then, of course, how do we use that data as providers, as educators, as nurses? How do we advise these patients on the information that these continuous glucose monitors collect? So we'll get started. So essentially, how do they work? All continuous glucose monitors work on the same basic premise. They're all reading the glucose measurements in the interstitial fluid. So the actual sensing device portion is in subcutaneous fat when it's placed correctly. And it's going to, in most models, consist of four main parts in the hardware. You're going to have an adhesive skin patch. You're going to have a transcutaneous sensor wire that's placed into the subcutaneous fat, as I mentioned, and an electronic transmitter, the fourth piece being the receiver device. So each part does what the name implies. So the sensor senses, the transmitter transmits, and the receiver receives. I double down on that point because so many times if a patient is calling you and telling you that, hey, one of my pieces is missing, I didn't get it in the mail, the pharmacy ran out, I lost it. Sometimes they'll mix up the phrasing on which piece is missing or doesn't seem to be working well. So it's helpful for you as the working professional to be able to walk through and go, okay, are you talking about the part that sticks to your skin, the part that clips into the part that sticks to your skin? Is it the part with the screen on it that you see the numbers on, so that you can best guide them and assist them in that troubleshooting process? So this is talking about transcutaneous continuous glucose monitors because these are the most common model that you're going to see. There's several different brands. And there's one other alternative that I'll go over briefly, but it's much less common, so you probably won't bump into it very often. And I've got a mix here. I've got a Libre 3 sensor demonstrated because they had this beautiful part separation image, and then some Dexcom receiver and a sensor there on the side. Just trying to be inclusive. Obviously, the Libre and the Dexcom don't talk to each other because they're different brands. And so what's actually happening within the subcutaneous tissue? How does this work? So you don't need to know the ins and outs of it, but a lot of times knowing the fundamentals is going to help you to answer a more inquisitive patient's questions or to help you kind of clarify in your education message. So what is happening? I love this very simplified graphic here demonstrating that you've got your capillary blood vessels running through the skin. The glucose is able to, of course, move between the blood flow into the subcutaneous fatty tissue, moving around through the interstitial fluid. So that, as I tell patients, is the juice between your skin cells, right? So it's floating around freely there. The CGM, or continuous glucose monitor, then has a sensor wire placed into that skin where it's picking up the signal. So on the right side of the slide here, I've tried to lay out, I know this is wordy, but just so that you have it there to reference what is actually happening, because it's nice to say, oh, it just senses the sugar and just tells you a number. So at a functional level, mechanism of action, what is happening? So the glucose is now in the interstitial fluid in the skin. The glucose is going to interface with that CGM sensor wire, which is coated with a sensing substrate. In the case of most transcutaneous continuous glucose monitors, it's usually an enzyme called glucose oxidase. And so that is an enzyme that oxidizes glucose, right? That's the beautiful thing about enzymes. They always tell you what they do. It's kind of how they introduce themselves. But that chemical reaction in oxidizing the glucose spits out some different ions. Typically, it's free hydrogen ions with a side effect of a little bit of hydrogen peroxide or some other water molecules. And in generating those ions, of course, ions have an electrical charge. So that electrical charge then gets picked up by the cathode, the electrical portion of that sensor wire, and that electrical signal gets passed up the cathode via just electrical charge transduction to the transmitter. The transmitter is the computer chippy part. This is the brain of the operation. There's very sophisticated algorithms going on in there that, quite frankly, I'm not a software engineer, so I wouldn't be able to explain it even if I tried. But it maths, it does some math. And then it says, hey, here's the math answer. And it spits that math answer out, usually via Bluetooth transmission. So it'll typically Bluetooth that data to a receiver. The receiver can be either the manufacturer supplied device. It can be the patient's personal cell phone. It can be the patient's insulin pump. So long as it's compatible with that particular glucose monitor's algorithm, it can be a receiver. And it really depends on what's best for the patient as far as what they like to use as a receiver. So whatever is effective for them. And then at the receiver end, that's where the data is being utilized by the patient and by the providers and educators. So a couple common brands that you may bump into of transcutaneous continuous glucose monitors in the United States. You're most often going to be seeing either a Medtronic Guardian, which is typically going to be paired to a Medtronic insulin pump. I don't meet many patients who use that CGM independent of an insulin pump. There's also 3 models of Freestyle Libre made by Abbott, which are available. So there's the 14-day Libre, the Libre 2, and the Libre 3. These are great, typically lower cost models. So they're very popular, very common. At this exact point in time, they do not interface with insulin pumps, although they have, I do believe, been FDA approved to interface with the Omnipod 5 automated insulin delivery system. And then there's the Dexcom G6 or G7. So the G7 is the smaller Dexcom transmitter that you see on the left side of the picture. And then the G6, of course, is labeled as G6 in the image. The G6 is the older model, G6 for generation 6. And as such, its algorithm is FDA approved and currently in use with insulin pumps, whereas the G7 being newer has not gotten that compatibility thumbs up from the FDA just yet. So usually if they're wearing an insulin pump, look for Medtronic Guardian if it's a Medtronic pump, Dexcom G6 if it is either an Omnipod or a tandem t:slim pump. And Libres at this time are not usually interfacing with an insulin pump just yet. And then some less commonly seen options would be a subcutaneous continuous glucose monitor. At this time, there's only one brand active in the market, and that would be an Eversense continuous glucose monitor. It's a very clever option. It is placed and replaced by a provider every 6 months, and it's placed under the skin, typically in the back of the arm. It's very similar to, if anybody's familiar with the subcutaneous birth control rods like Nexplanon, it's placed very similar to that. So the provider numbs the skin, makes a small incision with kind of a loaded needle barrel, and you insert it into the skin and maybe throw a suture in it. I don't think you even need a suture. You can usually just put a little butterfly over it, a little butterfly tape over it, and heals up. And in 6 months, you make a little incision at that same incision site, pull it out with forceps, and you can reinsert into the same space, I believe. Of course, you need to have a qualified provider to place and replace this device. And I do believe that the company does do the placement and replacement if you don't have a provider in your area. Now, this device is unique. It does not use enzymes in the way that the transcutaneous continuous glucose monitors do. This one uses a fluorescence substrate. So the glucose interacts with this fluorescent substrate on the surface of that little sensor kind of cathode you see the little fingers holding there on the far left. And the glucose actually makes the sensor send little light signals under the skin. And so it's the light that gets sensed rather than electrical charge. And then those light signals get interpreted, again, via very sophisticated algorithms by the transmitter. The transmitter then sends that data to the phone. Some really unique options with this and some reasons why patients may be interested in pursuing this less commonly used device is that the transmitter that is on the external surface of the skin is removable and replaceable multiple times, however many times you want in a day by the patient, because it's not transcutaneous, so it's not crossing the surface of the skin. You can take it off if you're going to go rock climbing or sailing or something where you might be at risk of losing your transmitter, and then you can place it back on when you're done with that activity. When you are wearing the transmitter, rather than an auditory alert, it will actually give the patient a vibratory alert if their sugar is out of range. So it can be a little bit more discreet for those patients who don't literally want their glucose alerts being announced to the room while they're at work or with family or, at a special occasion. So it can be a little bit of a better fit for patients that are highly active and wish for a more discreet device. I did want to list a few common questions that I very often anticipate when I'm introducing patients to continuous glucose monitors. Hopefully this presentation will answer most of them for you, the viewer, but you can also use this information to answer and anticipate patient questions. So first question most people are going to ask is it accurate? Well, gosh, I hope so, right? If we're putting it on patients and making treatment decisions based on that, I think, yeah, you should be able to bet that, yes, it's accurate. I have a lot of accuracy details coming up on the following slides. So I'll show you how we determine whether these I didn't invent them, but how it's determined that these devices are accurate. And then a very common question that I'll get is, why don't my finger sticks match my sensor readings? And that can be a major point of frustration for patients, because in their mind, they're thinking like, this is an equivalent one-to-one replacement of a finger stick, and so all of the numbers should match. I like to educate patients that there is a 10 to 15 minute time delay between any glucose changes in the blood until they're reflected in the interstitial fluid. And I always emphasize this is true for pretty much all metabolites in your body. It doesn't matter if it's a glucose change, a salt change, a protein change. If it's shifting in the blood, it takes time for that to then be reflected in other body parts. So if they are really insistent that they want to do a comparison, your classic retired engineers really like to compare these things. Just tell them, you can do a finger stick if you're really eager to compare it, wait 10 to 15 minutes and then look and see what your CGM is saying. I usually try to tell patients, like, really, you only need to do the finger stick when the device recommendations indicate that you should, which is when your symptoms don't match the CGM readings. The CGM readings just aren't making sense. They're jumping all over. You think maybe it's not a good sensor. Use it when you need to validate, or if you're wanting to confirm those readings, then you can, but you shouldn't be poking your finger all day. That was the point of prescribing the device. Another question, some patients will be a little bit anxious about the idea of that wire being under their skin for prolonged periods of time. And they may ask, will the wire get stuck in there? Will it break off and stay in my skin? And I tell them, like, yes, of course, that's a risk. Things break. This is life. Do I have any experience with that happening to my patients? Maybe 1 in 5 years I've had that happen to. So I consider it to be extremely uncommon. As long as the patient is placing and removing the device as they're directed, the risk of that happening is very low. The other question I get, sometimes patients seem to be a little unclear of the intention behind sharing this device, and they think that it not only measures their glucose, but administers medication. So make sure that you're very clear. A continuous glucose monitor continuously monitors your glucose. That's all it does. It does not administer medication. It is not there to treat your diabetes. It is there to just show you what's going on. And then patients often will be very excited about the prospect of not poking their fingers. Can they completely eliminate a finger stick glucose meter by wearing one of these? No, they cannot. There will still be instances, because these are computer hardware pieces, they may occasionally fail. They may occasionally just be a bad batch, be a little inaccurate. You might get a delay in your delivery supply or your supply delivery. You might have a pharmacy that's low on stock and doesn't have the sensors you need. You still need to have a finger stick glucometer for backup, for validation of your sensor, for use in acutely ill settings where you really need to confirm that you're either very high or very low before implementing insulin treatment. So you always need to have both. It's nice to not have to have 1,000 test strips, maybe just 50 test strips for 6 months, but it still is something that you need to have unexpired and working in good condition in your home. So doubling back to the accuracy, because I brought that up as the very first question at the top of this slide. This comes up very often. I wouldn't necessarily go into what is marred with a patient, but for this audience, it's nice for us to know. Maybe you do have a patient that is able to kind of understand a more in-depth answer. So marred is the mean absolute relative difference between a CGM reading and what we would consider like a standard of care measurement. So what we want is a lower difference, right? I don't want a large relative difference. I want a small relative difference so that I know that my standard measurement and my continuous glucose monitor measurement are as close as possible. So the lower the MARD, the more true to a standardized measurement. So we use this metric to validate measurement performance in CGM systems. You can utilize this in any various systems, metabolite measuring systems, but this is certainly used in CGM. In clinical studies, oftentimes you'll see the MARD calculated as compared against a commercially available capillary blood glucose meter, so like a finger stick meter. And so that would be, say I wanted to do a study in my hospital, I'm going to use the whatever brand Accu-Check finger monitor I've got on the floor and compare that against the CGM. So usually in a clinical study, that's what that's compared against. In laboratory and product development and approval studies, that CGM data is not compared against a commercially available finger stick monitor. They're compared against a specific laboratory quality YSI serum glucose meter. And so YSI is just a brand, Yellow Spring instrument. They're kind of the most ubiquitously used brand for laboratory technique in measuring most anything. I know when I was in grad school, we had YSI everything. I mean, thermometers, salinity measures, your pH meters. So this is a brand that is very easy, not very easy, but very particular high quality calibration so that it's considered very reliable. And then I took a quote that I felt like just sort of summarized the concept nicely from one of the papers in my work cited, if you wanted to look at it, just stating that the MARD is computed using temporally matched glucose data from CGM systems and comparison of glucose measurements, most often obtained by capillary blood glucose measurements of all subjects in a clinical study. So all that means is if I checked your sugar at 6 a.m. with a finger stick, I'm going to compare that to the 6 a.m. In my opinion, it should be probably 5:50 a.m. CGM data, right? And I'm just making sure that at each of those checkpoints that are considered matched in time, how close was that glucose? So that's essentially what the MARD is looking at. It's a little bit more complicated of an algorithm than just like, how close were they, right? There's an actual math problem behind it, but we don't need to go into that. But all that to say, in the short version, when I'm teaching a patient about it, usually what I tell them is, look, these devices are considered accurate enough to deliver automated insulin through an insulin pump to children as young as 4. So if it's safe for a 4-year-old to receive their minute doses of insulin through, I think we're okay, right? As an adult, your glucose measurements are not less important, but that's just to show you in pediatrics, these are highly trusted. So a few breakdowns. I really appreciated these charts that I found summarizing all the different models over time from the different CGM manufacturers. So the first one here is Medtronic CGM data, basically just demonstrating how the different models have changed over time. What was their MARD? You can see on the third row down, and then some of their other characteristics. So the current iteration of the Guardian from Medtronic has a MARD of 10.6%, which you can see is dramatically improved over time, where their first model was 17.2%. And then some other key characteristics, if you're trying to decide which CGM is right for a patient. The Medtronic has to be changed every 7 days, and it does need, on the G3, the Guardian 3, it did need to be calibrated every 12 hours, so twice a day, but their current iteration only needs to be calibrated once on the first day. So that's a huge improvement, because for quite a while, that was a major complaint with that product. Can you share the data? Yep, you can wirelessly share it through the phone app with up to 5 people. Does it have safety alerts for highs and lows? Yes. And does it have any interfering medications? The Guardian 3 does with Tylenol, acetaminophen. The Guardian 4, we don't seem to know that yet. And then any insulin pump compatibility is listed there on the bottom. Again, Medtronic is only compatible with Medtronic. So their Guardian 3 is compatible with their MiniMed 670G, and their Guardian 4 is compatible with their newest model, the MiniMed 780G. And then here's some Dexcom throughout history. So you can see that their current, if you look all the way to the right, their Dexcom G7 has a pretty low MARD of 8.1% when it's worn in the arm and 9.1% when it's worn in the abdomen. I love that they were able to get this indicated for arm wear, because anecdotally, not officially, I'll tell you, most people were wearing their G6 in their arm. So it's nice to know that they got the real world use approved for this model. And again, you can compare, looking back all the way to the left, of their original short-term sensor only had a MARD of 26%, so not particularly strong. Now it's very robust, 8.7% or 8.1%, excuse me. The length of wear, longer than the Medtronic. Dexcom can be worn for 10 days. And the newest model has a very short warm-up time. I didn't mention that on the Medtronic. The Medtronic, if I go back, has a 2-hour warm-up time. So that's basically, the sensor is soaking in the interstitium. So it's kind of getting in there and getting that fluid in and on the sensor. So the newest model of Dexcom only has a 27-minute warm-up period, whereas all prior models had a 2-hour warm-up. You can share with up to 10 people. And now the Dexcom G7 transmitter is one piece with the sensor, whereas prior Dexcom models had a sensor and a transmitter that were physically separate, and you had to attach the two for wear. So now you just peel it off, throw it away, put a whole new system on. And as of yet, the Dexcom G7 does not have insulin pump integration, although if you look, as I mentioned before briefly, the Dexcom G6 does have both tandem and Omnipod integration. And at this time, we don't know of any medication interference with the G7, although we do know quite well that the G6 does have some vitamin C or ascorbic acid and salicylic acid interference. Usually these interferences are fairly modest. You would only be seeing patients who are critically ill getting high enough doses to interfere with the CGM, in which case they're probably not supposed to be going by any CGM data anyway. And then looking at the Abbott Freestyle Libre CGM models, there's a nice little handful here. So the Freestyle Libre Pro first came out, had a MARD of 12.3%, and we go to today, and the Libre 3 MARD is quite low. It's 7.9%, which is lovely. Now, these sensors have the longest duration of wear, so you can wear them for 2 weeks or 14 days, and they warm up in 1 hour. Now, these can definitely be shared with other people. They do have alerts for highs and lows, like the Dexcom and the Medtronic, though you do want to be mindful that the 14-day Libre, which here just says Freestyle Libre in 2017, that's the 14-day model, that one does not have alerts. So there is no auditory warning for highs or lows. The patient has to be scanning and looking at their receiver to know what their sugar is. Their attention is not brought to the issue, whereas the 2 and the 3 both do have safety alerts. They both do have some medication interference with vitamin C and aspirin, again, usually in pretty high doses. So people that are taking emergency or airborne packets as immune boosters, and they're taking it maybe daily, that's definitely going to skew the CGM accuracy. And at this time, they do not have insulin pump integration, although, as I mentioned before, believe the 3 is approved for the Omnipod 5. Now, the paper that I pulled these charts from came out early in 2023, so I believe any of that FDA approval happened after that. And then here's a quick slide on the subcutaneous or implantable CGMs, as I mentioned before, the Eversense. So Dexcom at one point had been working on an implantable sensor, not approved by the FDA, had a pretty wide MARD, so 16 to 25%, not that great. Obviously, you'd probably rather wear the G7 and get that 8.1 MARD. So I'm not, we wouldn't pursue that one. And then if you look at the Eversense iteration since 2018, they've improved their MARD from 11.2 to 8.5%. You do need to calibrate the Eversense for the first 3 weeks, but remember that might sound like a lot, but you wear it for 6 months. So for the first 3 weeks, yes, you're finger poking at least twice a day. Then after that, you're doing 1 a day for the remainder of the 6 months. But again, you don't have to change that sensor so frequently as the transcutaneous devices. And you can share wireless data. And at this time, there is no insulin pump integration. And we do have some interference here with tetracycline and mannitol medications. Okay, so I've already touched on these, but just to lay it out visually, CGMs that are compatible with insulin pumps, we now call this either a closed loop system or an automated insulin delivery device. You'll hear it used either way. Oftentimes you'll see it shorthanded as AID, so automated insulin delivery. So as I've mentioned several times now, the Medtronic really only talks to Medtronic. So typically it'll be just the newest Medtronic will talk to the newest Guardian. You can use the Guardian without the pump, but as I mentioned, I don't typically see that. I usually only see it paired to the pump. And then the Dexcom G6 is compatible with the Tandem T-Slim, which is a tubed insulin pump. You can see pictured there. And with the, there you go, and with the Omnipod 5, and the difference here between these, as far as the data transmission, the Tandem is going to consider the Dexcom data and adjust insulin delivery every 30 minutes, versus the Omnipod 5 conveniently adjusts every 5 minutes. That's easy to remember. Totally a coincidence. It just happens to be the 5th generation of the Omnipod, and it adjusts every 5 minutes. But basically, again, it takes that Dexcom reading into consideration and adjusts every 5 minutes in tweaking the insulin delivery rates. Alrighty, how do we pick who we want to get a CGM? So there's certainly professional guideline recommendations on who can benefit and who should be encouraged to wear a CGM, but then there's also your clinical impressions. So you knowing a little bit more about these devices, ideally now, or having been curious and reading up on them or having experience with them already, you should be there to kind of help guide these patients as far as which CGM might be a best fit for them, and will they benefit in general from having access to CGM data. So the ADA recommendations for CGM wear are that real-time continuous glucose monitoring or intermittent scanning continuous glucose monitoring should be offered for diabetes management in adults with multiple daily injections or class 2 device closed loop insulin pump. So basically they're saying you really should have CGM data if you're taking multiple doses of insulin a day, whether that be by injection or by subcutaneous infusion with a pump. They also recommend a grade A recommendation for real-time continuous glucose monitor and a grade C recommendation for intermittent scanning continuous glucose monitor to be used for diabetes management with adult patients using basal insulin. I feel very strongly that even basal insulin should be monitored closely with a CGM. Oftentimes, I will see that patients are being what we call over-basalized, where they're getting large doses of basal insulin. They're having hypoglycemic events every night, and if you didn't have that CGM on, you wouldn't be aware. So it's a huge asset for patient safety. So you can see these are grade A recommendations from the American Diabetes Association. It's very highly encouraged. And similarly, for the American Association of Clinical Endocrinologists, their phrasing is that CGM is strongly recommended for all persons with diabetes treated with intensive insulin therapy, defined as 3 or more injections of insulin per day or an insulin pump, pretty much the same as ADA's first line. And then CGM may be recommended for individuals with type 2 diabetes who are treated with less intensive insulin therapy. So that phrasing is pretty broad to me. That suggests like some insulin, right? So probably basal. And if you're getting any insulin, really, it's wise to have access to CGM data. Some clinical considerations. So when you are, you know the patient, you've met them, you've spoken with them on multiple occasions, hopefully before we're counseling on CGM use. We need to know, does the patient want the CGM? Are they interested? If they're not interested in having that device on their body, they're probably not going to wear it for very long. Sometimes you can get a patient to wear it short term if you say, look, I just really need help interpreting your glucose patterns. Can you just wear one for me for 2 weeks, bring it in, we'll download it, and then I can help you out and figure out why you're having some of these glucose control concerns. Certainly, this is a great tool for patients who are fearful of either low or high glucose. So if they are patients tend to lean either one extreme or the other. Either they're most fearful of highs and they just hammer their sugar down constantly, or they're very fearful of lows. And so they're more comfortable leaving their sugar sit in the 200s. And you're trying to encourage them like, no, it can be safe in the middle ground, right? Let's work our way toward the middle. And so having access to see that their insulin dosing is effective and safe really helps to reconfirm for them, like, yeah, this works. I'm safe. This is okay. All this diabetes education I've received has been useful. And then does the patient have appropriate education support for training on the use of the device and its interpretation? So handing a patient a prescription for a CGM and then just good luck, kiddo, is not necessarily recommended. You want to make sure that if they have a device that's going to give them alerts for high and low glucose, do they know how to address their high or low glucose? Do they know how to interpret that CGM data? Oh, this looks like it might be a little inaccurate because the numbers just jumped really high and low erratically and it wasn't a meal. Let me validate with a finger stick. So did somebody walk them through the setup? Now, these are devices that are designed for patients to self-implement, self-utilize. They should be able to follow the written instructions and take it from there. But if they get a lot of data, you really need to know that somebody's there to guide them on how to interpret that data if they would like to. And then do they have continued access to the supplies? So it's great to hand somebody a sample of a CGM sensor, but can they afford the copay? Does their insurance coverage? Does the insurance cover it? Is it reasonable to expect that this patient will be able to continue use of this device if they want to? And then certainly, reflecting on that patient as an individual, are you at risk of precipitating increased healthcare related anxiety over alerts or constant data availability? I think this ties in a lot more into, did they have access to appropriate education on the device? But sometimes you can meet a patient who says, I really want to do better. I want to, focus on my diabetes. And you give them a CGM to help them to see, okay, which foods are making your sugar go high. But sometimes those patients will get like analysis paralysis. They get really fearful of lows or highs. I've met patients who basically stop sleeping because they'll sit and watch their CGM because they think that one piece of cake that they ate is going to make their sugar stay 300 all night. And so they're just watching to see what happens. So you do have to, know the patient and be confident in pulling the plug if you find that it's being disruptive to their quality of life. This is not a huge portion of the population. I just mention it because you want to make sure that you're giving your patient a fair assessment on whether or not this would be a comfortable, appropriate, life-enhancing device. You don't want this to be inhibitive or to create anxiety or frustration. So how do we use our CGM data? I have a very fundamental overview. Really, in my opinion, how to use CGM data is, like most things, is experience driven. You have to kind of test and try different techniques to try to get that CGM data to smooth out. But I'm just going to run through kind of the basics on what does the CGM data present to you when you download it and how do you initially evaluate that. So all CGMs, basically by virtue of the American Association of Clinical Endocrinologists, have this AGP report. So this is an ambulatory glucose profile report. And what this does is it summarizes the glucose values into some statistical information that really helps you to understand an overall assessment of glucose control, the amount of variability in the mean glucose data, in order to evaluate any patterns of big highs or lows. And then you can also break it out into single day glucose values. So if the patient says, last Wednesday, my sugar was crazy and I couldn't figure it out, you can pull up and look at last Wednesday together and, kind of dissect it out from there. I strongly encourage, and I think most people who utilize CGM data often would say the same, you want to start with the AGP report when you yourself are interpreting the data, but then also when you're sitting down to discuss it with the patient. So I literally tell them, hey, here's our bird's eye view. These are the statistics. This looks better than last time, or something seems to be different than last time. Let's, it's nice to have last visit's AGP report and current visit's AGP report, so you can kind of highlight some of the differences there. So some examples of what they look like, they're fairly uniform. I grabbed a Libre and a Dexcom AGP report example, each from the manufacturer's websites, just to demonstrate that essentially they're the same stuff, right? So on the left, we have the LibreView.com platform presentation of the AGP report. On the right, we have the Dexcom Clarity website presentation of the AGP report. You can see that you have a couple pieces of information here. So you have the average glucose, you have the time and range. Usually I start by just sharing with them, hey, your average glucose has been, if I look at this Libre patient, your average glucose has been 156. That's not too bad. So if we compare that to their glucose management indicator, which is sort of an equivalent of an A1C, that would suggest your next A1C should be around 7.0%. That's quite nice. And then I would look at their specific time and range percentages. So we want our time and range for lows to be, the next slide will lay this all out, but we want that to be less than 4%. I personally recommend I try to stick with less than 3% just to be a little bit safer. Time and range, we want that to be at least 50% of their time spent between 70 and 180. The golden number, the pie in the sky target is actually 70%. So I love that it's 70% because it's attainable, it's realistic. And then the rest, the highs above 180, I tell my patients that's just your proof of humanity. I like to reassure them I'm in the business of caring for humans, not robots. So I really don't expect you to have 0% above 180. Above 180 is just a cookie because you wanted one, and that's okay. And then you can see down below in both AGP reports here, there's some trend data. Now, those are averages. Those are percentiles and then the full range. So this is a great bird's eye view. And for some patients who have a very predictable schedule, it can be a good representation of their day to day, but it's also useful to pull up the daily reports and say like, okay, so the range on your, again, I'm just going to look at the Libre one because they've got those nice arrows kind of pulling it out. On the Libre one, I'll go, okay, so your range was pretty wide toward the end of the day at bedtime. You can see their peak sugar at the end of the day had been 350 at one point and had been as low as 70 at that same time in the day. So that's a big window. I'm going to probably expect there's a lot of changes happening at that time of day. So rather than just say, oh, dinner is super high all the time, sometimes it's low. So I'm going to pull out individual days and pull that apart with the patient. Okay, so time and range goals. Specifically, here are those targets laid out in a nice little graphic. So we want our lows to be less than 4%. We want our time and range ideally to be 70% or greater, the more the merrier, of course. And then our highs should really be, no more than 25 to 30% of the day, depending on where that time and range at target is. So when I'm walking through this with a patient, this is a great place to set some goals as well for the patient on their individual day-to-day targets. So we like to use a motivational interviewing technique, which is you want to sandwich it, right? You start with a good, you discuss a little bit of room for improvement, the bad in the middle, and then you end with something good. So typically I'm going to say, let's start by praising with areas demonstrating safety or maybe improved use of a technique that we had discussed at a prior appointment. So a lot of times I'll open up with, look at this, you're only having 2% lows. That's amazing. So I don't have to worry about you in the middle of the night. So that's really good. You're not going to be going low to a point or so frequently that you are unsafe on your insulin therapy. That's wonderful. And then we might discuss, okay, it seems like our time above 180 has increased these last few weeks. So let's look at a few individual days and see how maybe we could have improved that. And then at the end, you can set some clearly defined goals for them to work toward prior to your next evaluation. And again, praising them for this is really hard work. If this were easy, there wouldn't be specialists who do this. We wouldn't have to create devices like CGMs. And if it were easy, you wouldn't be here, right? So I validate the fact that you're trying really hard and keep working hard because it pays off. So then just to give some examples here as well on how to set tangible goals, it can be really helpful to evaluate those percentages as the amount of time that percentage requires to change. So 1% of our day is roughly 15 minutes. So if you want to try to promote a 5% time and range change, that means you need to find an hour and 15 minutes to improve in that patient's day. So that's where it can be nice to then walk through those daily examples, which I didn't pull up because there's just so many single day data points in a single CGM report. But the example I gave was, let's say our goal for our patient and with our patient is to decrease low glucose by 2%. So we're going to find 30 minutes in that person's daily patterns that occurs fairly commonly. And we're going to address the techniques in medication, diet, or exercise that seem to be preceding and increasing that risk of hypoglycemia. So how do we reduce it? So maybe the patient admits to you know what, that low right there was probably because I forgot to take my insulin before I ate, and I ended up taking more later because my sugar got so high since I was late on the insulin dose. Okay, great. Let's focus on taking our insulin before meals. Maybe their sugar was high through the night from having a big dinner or a dessert after dinner. They ended up taking their sliding scale in the middle of the night and they went low. Okay, so let's create a bedtime sliding scale that's softer since most people are more sensitive to insulin at night. etc. So this is where you customize it, but you try to find time blocks that are maybe most commonly occurring and address the events that precede those lows or highs, whichever one you're focusing on. I always focus on lows first because we want the safety profile to improve. So fewer lows. So an example, so this is actually data from a patient of mine who, let's see, when I met him, he was 22. And I met him in the emergency room, and he had been diagnosed as having type 2 diabetes since he was about 17. He had a normal BMI. So all of that made me a little nervous, like, ooh, is this really type 2? But he was not in DKA. He'd been without medication at all, no medication for 6 months. So, the likelihood of type 1 is less. Of course, I did a workup. We did, we checked for antibodies and all of this stuff. But the first thing I did is I asked him to please wear a continuous glucose monitor. So because I'm lucky to work inpatient and then hold clinic in the same hospital, I'm able to do things like place a CGM at discharge, show the patient how to use it, set it up on their cell phone, and then they can come see me in clinic, a week or two later, and we can look at that CGM data. So this was my patient's initial, let's see, this was about 20 days. If you look at the top left corner of that AGP report, 20 days of glucose data. Patient's average glucose was 176. You can see a more detailed breakdown on where my percentages were here. So we were only 0.1% of our time spent low, less than 70, 57.8% of time in range. The rest was high. And what's nice is that you can see by the median, the red line, that most of the rises in glucose were surrounding mealtime. So that's a big hint. We needed to work a little bit more on mealtime control. I was really relieved to see no lows at bedtime. Now, I had sent this patient home from the ED on basal insulin because I was not sure about type 1 versus type 2. So he was going to get insulin regardless. He had been on metformin prior to losing access to medication when he moved to the state. So I restarted some metformin, just a low dose, I think 500 milligrams twice a day. And that was it. I said, let's do that and follow up. Let's see how things shape up. Obviously, he's got this mealtime variability. So after getting his lab results back, confirming he in fact does have type 2, he just has a very robust family history of type 2. Then I was feeling more comfortable with selecting some non-insulin medications and implementing some different treatment options. So because he had all this glucose variability, this is where the kind of like practice of seeing and utilizing CGM data on a regular basis is really helpful. I saw we have these postprandial glucose rises. So I wanted to use a GLP-1, which blunts the rise of glucose after a meal. So we started a low dose of deglutide, the 0.75 milligrams once a week. And I did ask him to start using a bolus insulin sliding scale. Luckily, he had been educated on insulin back when he was 16 or 17 when he was first diagnosed. I think the same process probably happened because he was a teenager. They probably started him on insulin, presuming he had type 1 diabetes. So he had actually had some pretty thorough diabetes education. He understood carb counting, sliding scale, all of that. So I was able to just say, hey, here's your sliding scale, run with it. So about a month later, I think, let's see, we ended this report on August 8th. 2 months later. So this report ran from October to November. This is what his CGM data looked like. So much better and so impressive for a 22, 23-year-old young man in school. This is really, really good. So we were able to, again, reaffirm his efforts by showing him a positive change. He went from an average of 176 to an average of 131, which is incredible. But more importantly, his time in range has dramatically improved. So much less glucose variability, much more stability. So we're still very minimal on our low glucose. So maybe a total of 1% of his day is spent less than 70. 91.3 of his time is spent within our goal target range of 70 to 180. And the rest airs some highs here and there. Again, he at the time worked at Chick-fil-A, so sometimes he had a lemonade, sometimes he had fries, but whatever, go for it. So he hustled really hard, and we were able to confirm for him, hey, your efforts really work. And he literally shared that this device, it was not something he had used in the past, but wearing a continuous glucose monitor was a life-changing asset to him. It made a day and night difference. He was able to make changes that he knew how to do. It was just having the information available, and then, of course, implementing more appropriate medication to kind of help smooth things out. Now, if I had today's CGM report up, it's been probably 3 years. Is it going to be this perfect? No. This is a young guy who's working, who's in school, who's, in his mid to late 20s. His sugar has changed, of course, since then. But we know what works. We always just say, like, okay, when life allows us, we can return back to this. While you're busy and your school and work schedule's all over the place, your sugar is going to be a little more variable. But he has the tools and he knows what to do. And that's what's most important. So I hope that this example was a useful one just to show you, with good diabetes education and with access to information, the patient's safety is dramatically improved. I mean, it's truly a day and night. And this is not somebody who was severely hyperglycemic, right? This is someone who, if you looked at just an A1C value, you would probably say, okay, not so bad. An average of 176, maybe his A1C is 8%. Okay, whatever. But then you see how improving that time and range dramatically improved that overall average. I mean, that represents probably an A1C down in the, high fives, 5.8, 5.9, something like that. So it's quite nice. So that's all I've got. Here's a few of the works I cited, pulled some of those beautiful graphs and things from, and I hope this was beneficial to everyone, and I'm looking forward to taking your questions.
Good morning, everyone, and welcome to our live Q&A session. My name is Kinsey McNamee. I'm the account manager here at Medical Service Company. Thank you, Caitlin, for joining us, and thank you for that great presentation that you gave about optimizing diabetes outcomes with CGM devices. I really liked how you dumbed it down for us and put that in simple language that we could understand, kind of that complex device. So thank you. We do have some questions that we'd like to go through. So I will get started with the first one here. So first question is, with regards to clinical considerations for a patient being a candidate for CGM, how do you address a patient's concern about someone like watching their data or having kind of concerns over that data safety?
Yeah, that's a fairly common question, especially I'd say with some of my older patients who are maybe a little bit less tech comfortable. Usually I make a joke about 1984 Big Brother, right? But I always reassure them, look, these data points are, all of these CGM companies, in order to stay in business, need to be HIPAA compliant, right? So that data is secure. It's only accessible through a cloud connection that they can choose not to share. There are some patients who will say, yes, my phone is capable of connecting to this cloud service, but at that exact point, I probably have 3 patients who are like, I just don't trust whomever, the government, who knows. And they just choose to run it on the reader for the CGM. So that is a non-internet connected receiver device. And so they always have that option, and then we can just manually download it when they come in and you have a report then. Now that does, of course, imply that you are probably in an endocrine clinic space that has nurses that are trained to download, but it's not hard to do. And usually I just, I tell them, look, you have the option to not connect. That's totally fine. But if you call me between appointments and ask me to help you with your sugar, I can't see it.
Right.
And so the benefit is really for me, your provider, and you, the patient, to be able to be on the same page when we want to communicate over long distances.
And you feel like when you explain that, most people are like understanding?
Typically, yes. And I think it's also an important point, similar vein, but it's slightly different topic. It's very important to also have a pretty candid conversation with patients' family members if they're present, or their spouse, or their adult children, and say, look, your loved one's diabetes control is their business. You guys need to be frank about the nature of relationship. If your loved one having access to your glucose and getting alerts all the time about, okay, every time you eat a meal, your sugar goes up, and they text or call you, if that's going to be a nagging element and it's going to cause you guys stress, don't do it. Don't let your loved ones follow your sugar. But if the patient, clearly has dementia or early signs of dementia, and all of their adult children or their spouse or whomever would be like, for safety, I would really like to know if dad's sugar is hitting 30 every night. And that's why he's, stumbling around the house when he's trying to get up to eat. So, I always encourage patients to go, look, it's not just the security of the connection, but be thoughtful about the relationship of the people that you're sharing your data with too.
So do you deal with adolescents? Because I can just imagine like that transition of caregiver parents
Leaving the home,
monitoring to becoming an adult. I bet that's an interesting time to figure out who's in charge of the data.
Yeah. And timely, we just had our endocrine grand rounds yesterday. It was presented by one of my colleagues who is a physician dual certified in both pediatric and adult endocrinology. We were talking about exactly that age transition. So I have a fair collection of, I can only see legal adults. So I can only see 18 and up because that's my supervising physician's parameters, or like his licensure. So I do have a collection of 18 to, mid 20-year-olds. And if they have type 1 diabetes and it's been a process, usually their parents are at those first couple appointments because it's that handoff from being in a pediatric setting where so much of the care is in mom and dad's hands. And then, I think the difference is that because it's an adult clinic, I don't turn my chair and face mom and dad. I'm facing the patient. And I will tell the patient in front of their parent, look, these are your appointments now.
Right.
I'm happy that mom is here or dad is whoever. And I always encourage you guys to join if you have the time and it's helpful to you. But, I'm here for you. I'm going to be calling your phone. I'm not calling mom's phone. So I usually kind of establish that up front. And I expect that if a parent or anybody is uncomfortable with that opens that conversation and say, oh, we're not ready for that. But it's an adult, for me, it's an adult space. But yes, I think we do have to, especially if I'm dealing with like a young adult who's left the home and is in college, then, it's their first time away from mom and dad. Then I sometimes have to ask them like, hey, has this been helpful? Have you actually discussed with your parents if they are bothering you too much? Like, have you guys had a conversation? Because there's a lot of tension there. And everybody's relationships are so unique. And I think it's just really important to be respectful, both as a provider and as a family member or a loved one of a person with diabetes, in particular type 1, I'll say. But like patients have ownership of their diabetes. It is theirs. It is not yours. So I
think we have time for one quick question. So when prescribing a patient a CGM for the first time, what do you consider when choosing what device is right for them? Is there certain things that you look at?
The short answer is I give them the one their insurance will let you cover, right? That's at the end of the day, that's always the one. Now, if what would be my parameters for medically saying like, well, I'm going to argue with insurance, I'm going to get a specific one. Usually if I or the patient are suspecting that they may want additional diabetes technology down the road, typically this will be somebody with type 1 diabetes is what I'm thinking of, but, or if they're just bringing it up, if I want a CGM that is compatible with other devices, like an insulin pump in particular, I'm going to lean toward probably a Dexcom brand because that is a class 2 medical device. So it is approved to link with more than one brand of insulin pump. So the patient has like the most flexibility there. The Freestyle Libre is, I understand, FDA approved to link to the Omnipod 5. I have not yet seen that or personally used that in practice. So that's the reason I don't yet order Libres for the Omnipod. But again, that's only one insulin pump. So I kind of pick the one that has the most options. The only other thing I would do is you really kind of want to think a little bit bird's eye view. Is this a patient who they give me no glucose data, right? They give me one finger stick a week. I probably don't want a scanning sensor because that's still an action to take. As easy as that is, it's still an action that you can choose to do or not. So for that patient, I would probably not choose a Libre 2. I would pick a Libre 3 or a Dexcom where it's just passive data collection. And then I typically lean a little bit more toward a Dexcom because it has predictive alerts. If I have a patient, again, probably with type 1, who has very labile glucose. And I want them to have alerts that tell them, hey, a low is coming, not, oh my God, you're low. It's the difference between the analogy I give is like, you can have a smoke detector in your house that tells you something is already burning. That's kind of the Abbott alert when you hit a threshold. Or I could live in some future house that tells me, oh, you left the stove on, nothing is burning yet, but hey, my alert is for the fact that something could catch fire, right? So if I have
Caitlin,
people,
I'm sorry, but we got to cut you off.
oh, sorry.
We got great information. I hate
Great.
to do that because, it was some great information that you provided for us at the end there too. Thank you so much for your time today. Really appreciate you joining us, and have a great rest of your day.
Thanks. You too. Thanks for joining, everybody.
Thank you. Bye.
Bye.